Tracheotomy is the creation of an opening in the anterior tracheal wall. Tracheostomy, on the other hand, is the formalization of a permanent stoma by suturing the edges of the trachea to the skin. Over the years, these terms have come to be used synonymously. Indications include prolonged mechanical ventilation due to respiratory disease, neuromuscular disease, and depressed mental status, pulmonary toilet, surgical access for head and neck cancer reconstruction, extensive maxillofacial fractures, airway obstruction due to tumors, bilateral vocal cord paralysis, angioedema, foreign body, and even obstructive sleep apnea. Relevant anatomy includes the location of the hyoid bone, thyroid cartilage, cricothyroid membrane, cricoid cartilage, and thyroid gland. Instruments include your tissue tweezers, mosquito forceps, Cooper scissors, muscle retractors, Mayo needle holder, your parts of tracheostomy tube, your obturator, cuffed non-fenestrated tracheostomy tube, inner cannula, and your capped inner cannula. No contraindications exist. The patient should be positioned with the neck in extension. This elevates the larynx and brings up to 50% of the proximal trachea into the neck. Antibiotics should be given preoperatively for prophylaxis against skin pathogens. Prior to proceeding, the surgeon should palpate and identify the hyoid, thyroid, and cricoid cartilage. In an elective tracheotomy in a patient with easily palpable landmarks, the more cosmetically favorable horizontal incision can be used. A 2 to 3 cm horizontal incision should be marked at the approximate level of tracheal ring 2, about 1 cm below the cricoid. The planned incision is injected with 1% lidocaine with 1:100,000 epinephrine, and then the patient is prepped and draped in a sterile fashion. Begin by dividing the skin and subcutaneous tissue with a number 15 blade. The superficial layer of the deep cervical fascia is then divided vertically, taking care to avoid the anterior jugular veins and any crossing branches. Platysma layer is identified and divided using cautery, and this tissue is retracted. The strap muscles should be divided in the midline raphe and should be reflected laterally. The thyroid isthmus can be mobilized so as to expose the anterior trachea, or it can be divided. If the isthmus is divided, care should be taken to address any bleeding from the edges of the gland prior to opening the airway. The cricoid hook should then be used to secure the airway superiorly and anteriorly. It is imperative that the surgeon communicate with the anesthesiologist prior to entering the airway. In the intubated patient, it is recommended that the cuff of the endotracheal tube be let down temporarily so that it is not perforated with entering the airway. The tracheotomy should be created between the second and third, or the third and fourth ring. The airway can be entered in any number of ways to include vertical, horizontal, or H-shaped incisions. The author prefers a horizontal incision between rings 2 and 3 with the creation of a Jork flap. Once in the airway, the ETT is pulled back so that the tip of the tube is just above the opening. If necessary, this allows the tube to be quickly advanced to re-establish ventilation. The tracheostomy tube is then advanced through the opening in the airway, and the tube is connected to the ventilator circuit. Once the ventilator return and end tidal CO2 are confirmed, the cricoid hook is removed and the tube is secured in 4 quadrants with suture in addition to tracheotomy ties. Complications include intraprocedural complications like airway fire, bleeding, pneumothorax, or pneumomediastinum. Early complications include infection, tube obstruction, and accidental decannulation. Late complications include tracheal stenosis, tracheoinnominate fistula, tracheoesophageal fistula, and tracheocutaneous fistula.